So we're now recording. Terrific. So we are recording the session so we can make it available to those who aren't able to join us this morning and are interested in the content of this webinar. So I'll introduce myself. My name is Mary Fliss. I am the Deputy for Clinical Strategy and Operations here helping Beth Tinker with this project. And Beth, would you like to introduce yourself?
Sure thing. Thank you, Mary. Good morning, everybody. Thank you for being here with us. My name is Beth Tinker. I'm a nurse and I am a clinical nurse consultant at the Healthcare Authority.
Awesome. And also joining us helping with this webinar today are Stella Chang and Bob Swan. So Stella and Bob, could you say hello to the group so they can recognize your voice if you need to intervene as we go forward?
Yep. Good morning, everybody. My name is Stella Chang and I'm with the Healthcare Authority.
And I'm Bob Swan, also with the Healthcare Authority. Thank you.
Wonderful. All right. So we have a couple goals today. The first is to provide general updates on the work as it has been progressing with our maternal care model. You may remember a few months ago, we met as we launched this work and introduced to you what we were working on, the topics that we hope to review, excuse me. So we do have some updates on the work that we've done. And very importantly, we're hoping to receive feedback and input from you as a team, and really appreciated in our last webinar, the robust conversation we had and the input that you provided. So look forward to having more discussion today as we've been moving forward. And also we will be looking specifically in terms of those action items, includes why we care, some of the related work that has been going on around maternal care within the state, our project timeline, some questions, some time for questions and feedback, and then we'll provide you with resources and contact information. So with that, our agenda and what we're hoping to accomplish, let me go ahead and turn it over to Beth.
Thanks, Mary. So this is Beth again. So just a bit of context, and I know for a lot of you, or most of you, this is probably well-known and background information, but always feels important to elevate why we are doing this work. So I'm not just going to read this here because I'm sure you all are reading it, but just to layer on, you know, we are not getting value out of our current maternity care, either during pregnancy or in the postpartum period. And by that, I mean the US has some of the worst perinatal and infant health outcomes, certainly in terms of the developing high income and developed countries, right? The US has the highest rate of maternal death in terms of the developed world. We are the most dangerous place to have a baby, and that is especially true for birthing people of color. And frankly, our maternal mortality rate has doubled in the last 25 years. And so that is alarming. And I think we should be alarmed and we should be outraged, and particularly around the disparities in those deaths, as well as in other outcomes. We have a very high rate of intervention around pregnancy. C-section rate is a fair marker of that, and a very common one. Preterm and low birth weight in this country are higher than most other developed countries. And again, that is particularly true for people of color. And just broadly speaking, folks are fairly dissatisfied with the care that they get. Of course, there's variability, but at the population level, folks are generally pretty dissatisfied with the care that they receive and are not getting the behavioral, psychosocial, social related health needs kind of support that is really necessary to benefit the population. And the postpartum support in particular is generally lacking. This is more on kind of the same topic. We are lucky in Washington State to have a maternal mortality review committee, so that is specific to our own state data. Our committee has found that about 60% of maternal deaths are preventable. This actually mirrors national statistics when looking at all of the states across the country that have a maternal mortality review panel, but it is also true in Washington. So, you know, we should be working on those preventable deaths in particular. Again, the driver for maternal deaths, certainly in that later postpartum period. So once folks are past either kind of the 60 or 84 days postpartum, the drivers are really behavioral health for those preventable maternal deaths. And in that, we are talking about accidental overdose and suicide. Again, here calling out, I think every slide in this deck, we could call out disparities, and we will often, because it's important, and we should be elevating our disparities and attempting working to address them at every opportunity. In Washington State, African-American Black folks have about 3 to 4 times the risk of death. But it is our Native American, Alaska Native birthing people who have about 10 times the risk of a pregnancy-associated death as compared to the reference white population. And just another mention of why we care. Medicaid pays for just under half the births. This gives us tremendous opportunity and also obligation to do better. We want to pay for high value care. That is care that results in better outcomes per dollar spent for this population of folks. And frankly, if we're not investing in the pregnant birthing population and infants, if we're not investing in early life, what does that say about our humanity and our really desire to see a healthy population going forward? Okay, that's why we care. So what has this work been building off of? This is really just to highlight kind of a host of different initiatives and work that's going on. I can say a little bit more about the BRE Collaborative if folks aren't familiar. So this was established by the LEG back in 2011. It's a public-private partnership. They elect every year to work on different kind of clinical focal areas. They want to work on things where there's variation in care and outcomes, where there's opportunity to improve population level health, and also potentially to reduce spending, although that's not the primary goal. It really is about improving population health and decreasing variation in care and in outcomes. So back between 2019 and 2021, the BRE Collaborative worked on a perinatal bundle. And I'll say a little bit more about that on the next slide. The other things that we have ongoing, hopefully everyone's aware of APC, after pregnancy coverage, which is our name and our acronym. If everyone's knows, Medicaid loves acronyms, but after pregnancy coverage is the name for the 12 months of comprehensive postpartum coverage, and that was implemented in Washington State in June. We do have a maternity episode of care in terms of regions and our one of our commercial lines here at the Healthcare Authority. So that's another current work and initiative that we look to in this project to see how are we aligning what has been the outcomes of that episode of care, and how do we want to mirror, or are there areas where decisions that were made do not make sense or not what we would want to do for the Medicaid population. We are at the Healthcare Authority, along with a number of partners, some of whom probably are on this call. We are currently participating in a IMI, Institute for Medical Innovation Learning Collaborative, with a focus on how we can increase access to midwifery care. That is both an equity initiative. It is also just an outcomes. Frankly, it's also workforce. There's a lot of components to it, but again, broadly speaking, evidence shows that folks are more satisfied with midwifery care, and outcomes are also better, even when controlling for risk, which always comes up, of course, when we're talking about pregnant folks who are clinically eligible to have a midwife as their primary OB provider. And when we talk about midwifery, we are including both CNMs, certified nurse midwives, and also licensed midwives, both hospital birth and community birth, always based on client and family voice and choice in terms of the model of care and the delivery setting that they desire. And then we have considerable amount of work going on at the HCA in terms of infant and early childhood mental health. We've recently implemented new policies and programs, are doing a lot of outreach and communication, and we have some great experts on our team at the Healthcare Authority who are focused on infant and early childhood mental health, which of course is just the continuum. Sorry, I keep talking. I'll say next slide, and that'll help you.
Okay.
I just want to call out that, perinatal mental health and infant and early childhood mental health are really the same continuum, partly why we include that here. And just broadly, we are really working on thinking about that dyad, right? The birth parent and the infant is not these two separate entities that are unrelated, but two lives and trajectories, sometimes more than two, that are inextricably linked, codependent and reciprocal. And how do we really provide care that is best supporting both the birth parent and the infant? Okay, next slide. So a little more about the BRIE, because the BRIE work is really foundational to our ongoing work. So again, I mentioned that the BRIE Collaborative selected and worked on a perinatal bundle between 2019 and 2021. So they really identified a host of opportunities for clinical improvement, including reducing unnecessary cesarean section rates, increasing the provision of care by appropriate providers and appropriate settings. So that certainly includes that midwife piece that I already mentioned, reducing preterm birth rates, mortality rates, both for birth parents and also for infants, and then certainly reducing health disparities. So some of the clinical improvements that were identified, that are identified in the BRIE perinatal bundle, identification and treatment of cardiovascular disease, increasing rates of physiologic birth. When we say physiologic birth, that is minimal intervention birth. It's really supporting the natural ability of a pregnant person's body to proceed through the birthing process and not jumping to interventions that may not be necessary, which, one intervention often, not always, leads to another. So promoting physiologic birth is really sometimes referred to as natural birth. So behavioral, I mentioned cardiovascular, behavioral health is also called out here. The BRIE also really calls out provision of more tailored and personalized care, particularly in the postpartum period, with more than just one comprehensive 6-week visit, which has sort of been the standard of care for many decades, although a number of OB providers and practices that are already really providing an earlier, say like a 1 to 2 week visit, but the BRIE really works to make that more the necessary or required kind of clinical care model. Improving postpartum care tailoring, patient-centered care. Yeah, of course. I think also just the BRIE also calls out value of team-based care and how we continue to work towards and elevate a team-based model of care, which again, there is substantial evidence that team-based care is better for patients. And so we're talking about, doulas or community health workers being included on care teams, along with kind of the more traditional licensed clinical providers. Okay, next slide. So now we're getting into our current work, our current healthcare authority work, although it's never just the healthcare authority, it's always us and all of our necessary partners and stakeholders and collaborators. But so what do we want to do with our maternal care model? Our goal is to incentivize high quality, high value care. So again, that means, oh, is this the right slide? Yeah, okay, sorry.
Yeah, sorry about that.
No, that's okay. High quality, high value care that improves perinatal health outcomes. So again, we are talking about both the birthing person and also the infant. And we are, again, intentional about our desire and our need to address racial and ethnic disparities. So then these are kind of some of the sub goals here. We are right now in the design phase still. For those of you who attended our last webinar, we were in the design phase then. We are still in the design phase, and we will be through the end of this calendar year, through the end of December. So our plan and what we will have at the end of this calendar year is a model. In particular, where we will design the model to help pregnant folks access prenatal and postpartum care, improving the quality of care that they receive. The primary lever is really incentivizing provider behavior change in terms of reducing maternal morbidity and mortality and increasing, this is the reason why we have clinical components built into that model that are required. It's also, you know, a key tenement of episode of care, a maternal care model, episode of care design is having opportunity for gain sharing or reward. So we want to reward providers and provider groups that are excelling and meeting certain targets. Next slide.
All right. So as Beth mentioned, we have, as this team knows from our last meeting, been working on that design and really trying to think through and work with our partners in NORC who've been supporting this work. How do we really strategize around an episode of care? And so we have called on other states that we know within their Medicaid populations. They have created different strategies. And one strategy is the episode of care model. And this model is again, as Beth mentioned, frequently uses risk sharing or risk sharing thresholds that are based on costs. And that can either be upside only, or it can be both upside and downside. So they take the typical cost of a delivery and wrap around all of the services, the professional services, the hospital services, et cetera, and say, this is the target that we're asking for providers to reach. If you beat that target, then you will be sharing in the savings. If you are more expensive than that target, then we are going to decrease the amount we pay you to recognize that. In many of these models, they will incorporate quality as a floor that must be met, or alternatively, they have that cost sharing on as one part of the model, and another part of the model is having a sort of a specific pay for performance. So if you meet this performance threshold, what we have found in states is that they are really being very specific and targeted with respect to the quality measures that they're selecting. So when you look at the outcomes that they're trying to derive, they're really focused their selection of quality measures and how they're talking about and moving forward with their strategies based upon those goals and those outcomes that they're looking for. And what we also found was that there is a lot of variety in the evaluation of the findings, and both in terms of how well they've done with respect to their quality metrics, as well as birth outcome results that they've seen as they have reviewed their episode of care. So we're really trying to learn from these states so we can make sure as we design this for Washington State that we're learning what we can and then applying it to the design that we start developing. The other strategy that we've seen being used by states is a more standalone strategy in which they're using, excuse me, either a health home model or a maternal medical home model. Both of these models are accomplishing similar objectives. Within the health home model, it focuses more on the primary care provider and incorporates the use of patient-directed health action plans. So those of you who are familiar with our own Apple Health health home model, there are those components. And as Beth mentioned, cardiovascular disease being one of those areas that is of particular import, they create a strategy where they're establishing this care coordinator and resource, and then doing quality measures around a health home. Another variation of that is maternity or pregnancy medical homes. Those are focused more on assessing and having targeted services for high cost, high need populations. So again, they may look at the specific populations where there is SUD or other specific behavioral health, serious mental illness that they're calling forth and saying, we have this targeted population. We want to have a specific wraparound service that helps those patients with those conditions in those situations to have better outcomes. And as we think about health homes and maternal medical homes, we're thinking about sort of the appropriateness in the context of our extended postpartum periods, and really wanting to make sure that our evaluations of the health home models, specifically for those with chronic conditions, what we have found in the literature is that when they have those specific health home models, they are receiving better quality of care. They have improved care coordination and management, greater integration of behavioral and primary care, increased rates of transitional care, and improved access to social services and community-based supports. And you may remember again from our last meeting together that we talked a lot about the dyad, and as Beth also mentioned, that sort of that parent birth birth parent and infant health is so inextricably linked, really wanting to make sure that those connections are being made and those transitions are being smooth and seamless for all of our pregnanting folks. So Beth, if you'd like to go ahead and start with our logic model.
Sure. Thanks, Mary. There's a lot on this slide, but just to kind of orient everybody, hopefully the kind of overarching goal on the left is familiar. This was on a prior slide, as well as the middle column, which has the goals, which are broad. And so I think the attempt here with this model is to drill down a little bit more on like, what are the strategies that we intend to activate or leverage to kind of meet those goals, which, you know, I hope and sort of assume the goals that are in the middle, there's a universal support for, right? Like, yes, we can and should be doing all of these things. So I'll just highlight a couple of the intervention levers. Some we've already mentioned, including the top one, which is really how can we re-envision postpartum care, you know, in a way, like how could we ever think about the postpartum period and postpartum recovery in terms of a person's kind of needs as one 6-week postpartum visit. I find that, and I worked in OB, a little baffling. But regardless, so how do we really look at that postpartum period differently, both in terms of meeting folks' needs in a meaningful way, and then also, of course, that we have this context within Medicaid of 12 months of coverage now. I will skip behavioral health because I will touch on that last and kind of tee up for our next slide. We absolutely need to do better at managing chronic conditions. If folks aren't aware, in terms of changing kind of demographics of the pregnant population, we continue to see increasing folks who come into pregnancy with an existing chronic condition. There's a number of reasons for that, but regardless, to say there is room for clinical improvement in terms of assessing, evaluating, treating across the continuum, prevention, promotion, and treatment for chronic diseases. And we know that pregnant folks are typically quite activated and engaged with the healthcare system, sometimes in ways that they have never been or not for a long time. And so how do we take advantage of that really in terms of chronic disease management? I will call out the next one too in terms of social determinants of health. Well acknowledged, it is not just folks' physical health, and it is not just folks' behavioral health, including both mental health and substance use disorder, but folks' psychosocial health. That is really important during pregnancy and that postpartum period. So how do we build into a model the expectation that providers and provider groups are assessing social determinants of health and linking or referring people and their families to services that will, you know, meet or certainly at least help to meet or aim to meet what some of their social and psychosocial needs are. The second to the top, behavioral health screening. Again, we talked a little bit about what our data shows in terms of behavioral health. Certainly also COVID. So if you look at kind of national statistics in terms of anxiety and depression during pregnancy, commonly referred to as the most common complications of pregnancy are anxiety and depression. And you might see 1 of 4 or 1 of 5 pregnant postpartum people will have either anxiety or depression. But when you look at data and research on the Medicaid population, it is a different story. It's typically more 1 in 3, and there's some research studies published during the pandemic that showed in some samples, perhaps not generalizable for the entire population, but certainly some well-done studies showing even 1 in 2, right? So these are major impacts in terms of the health and well-being of the population, and it's not just the pregnant birthing person, it is also the infant, and it is also the rest of the family. And so within this maternal care model and episode of care, how are we going to set up expectations around systematic behavioral health screening, referral, and follow-up? And again, when we say behavioral health, we are talking both about mental health and also about substance use disorder. So next slide.
All right, and the next slide is going to be a video of Dr. Fatino's. Really, Beth, I think, did a fantastic job describing the issues around behavioral health, particularly anxiety and depression. Another significant issue, as we know, is a substance use disorder, and it's an issue not only affecting the general population, but there are, as we can imagine, specific impacts to our pregnant population. So this video is about 6 minutes long, and with that, Stella, I think you're all set for playing the video, right? You have control now with the screen.
Hello, my name is Sharisa Patinos. I'm the Medicaid Director and the Behavioral Health Medical Director here at the Healthcare Authority. I'm sorry I can't be with you today, but wanted to spend a few minutes talking about people who are pregnant and experience substance use disorders. You just heard from Beth that is one of the focuses that we hope to develop a better care pathway, a better wraparound set of care services through the implementation of the maternal care bundle. We have a lot of initiatives and efforts that are supporting better care for folks with substance use disorder, a couple of which I'll mention now. One is we're looking to support the birth parent in staying with the hospital if their infant has been exposed to opioids or other illicit substances during pregnancy, so that birth parent can stay there during the period of observation for that infant, and that needed and appropriate resources can be brought to the infant and their parent while in the hospital. We're also looking to see if we can support people who are struggling with active substance use disorders in staying in the hospital longer to have some of their substance use disorder and mental health needs, if they also experience those, addressed before they are discharged from the hospital. So really trying to take a continuity approach to providing the most support that we can for a person who's pregnant, both during their pregnancy, their labor and delivery, and then postnatally. We know that in particular, communities of color, African American and American Indian Alaska Native communities suffer disproportionately from maternal mortality and morbidity, as do their infants. So how do we create the programs that we are? How do we stand up the tools and structures in a way that assures that communities that are most in need of these tools have resources that they want to make themselves available to, or more importantly, that they trust. So really we've thought about the episode of care with a focus on substance use disorders as one of the sort of focus groups, as a way to assure safer care, more person-centered care, and ideally culturally appropriate care that recognizes the strengths and needs of each person who is pregnant and will be parenting. So how would that work? What we don't have now are accepting attitudes of people who have substance use disorders. I was at a conference a few weeks ago that was about a perinatal conference with providers, patients with lived experiences, and providers, I mean nurses, physicians, social workers, who came together from across the state to really say, how are we doing? What are we missing? How do we better care for this population? And I would be remiss if I didn't say what I heard was sad. We heard women describe their experience as frightening, terrifying, actually. I think someone used the word. While both pregnant and in labor, they were dismissed, they were not treated well, they were not treated respectfully, they were not included in conversations about their care. This was both outside and inside the hospital. And a lot of that was due to the stigma that people with substance use disorders face. So if that is the environment in which you're seeking care, chances are good you're not seeking care. So how do we build in the tools and supports that would make people feel more comfortable in a setting, in a healthcare setting, where they would feel safe sharing their history, having someone who is empathic and able to help direct them to the resources they need, hear their story, and support them being a successful parent. We don't have that system yet, but that's where we're trying to go. And we see the maternal episode of care as a set of tools that we can use to better assure that communications that are important are made, that handoffs are made, that there are quality measures that look at, is that person being treated well, respected? If they are from a community of color, do they have access to people who look like them, who understand their lived experience? We know that doesn't exist now, and we're not going to build it overnight. But if there are ways in which we can incent the type of care that is delivered to people, then perhaps that will help make it the norm as opposed to the default. This is not going to be enough to fix or address the disparities that exist. But if we can figure out what care that is person-centered, culturally appropriate should be, we involve folks from those communities in helping tell us what it needs to look like. We create a payment structure that supports those needs. We have a better chance of getting there. Not the answer to fix everything, nor is it intended to be, but we do see the maternal episode of care with highlighting particular populations, for instance, those with substance use disorder, as a way to at least get our arms around bringing together more person-centered services, whether that be doulas or midwifery care, that are more congruent with the person's needs and desires. Again, we're not there. We've got a lot of things to put in place. But we hope this is a start by engaging you, getting your ideas, how we can better assure this seamless continuity of care between providers across prenatal care, labor and delivery, postpartum care, with ongoing follow-up, with mental health, substance use disorder, and medical conditions properly and adequately followed. And most importantly, people who have an experience that they are not ashamed of, that doesn't give them PTSD, and that they and their new infant have the best opportunity to be successful as they go through life. So thank you for attending. Again, apologies I can't be there, and have a good day.
All right. I'm just happy that worked. And I think the slide deck will come back up. I'll say, just want to share my thanks to Dr. Patinos for her comments, but certainly more broadly just for her support and guidance on this work, and her consistent commitment both to the pregnant birthing population and improving our care and outcomes, and also the subpopulation of folks who have substance use disorder. She's a great champion for all of this work. So next slide. So we've talked a little bit about the why. We've talked a little bit about kind of the what, and so this is a little bit of content on the how. So it seems important to call up value-based purchasing. If that's not familiar to folks, that's totally fine. It's so included in here some other kind of synonyms or ways that value-based purchasing is referred to. VBP is really conceptual, but the idea is to pay for performance or to pay for value. These are different, framed up differently, or sometimes in opposition to paying for volume. The paying for volume system is oftentimes the fee for service, which absolutely still exists, but there has been, I mean, this is probably over the last 20 years now, quite a movement among payers. This is both public payers like us, like Medicaid, and also commercial payers, to really move towards value-based purchasing, this paying for value model. Does it work? I think so. There's a huge body of literature on value-based purchasing. Certainly not my area of expertise, but I'm certainly growing in my knowledge and remain really curious. I think it's fair to say that evidence shows that there is opportunity with value-based purchasing to drive better care and better outcomes, opportunity that does not seem to be equivalent to a fee-for-service model. That's not to say VBP is a silver bullet. It's also not to say that there are not times and places where a fee-for-service model is really important and actually the right choice. If we want to incentivize very specific kind of interventions would be one example, but the value-based purchasing train has certainly left the station, and it continues to gain momentum. And so we are, absolutely looking at how we can utilize VBP in this maternal care model. Again, looking at the prenatal labor and delivery and that full year postpartum, linking payments to improve performance by healthcare providers. We are planning a pretty concrete, I would say, in our plan right now, that we will use an episode of care value-based purchasing structure from that initiation of prenatal care through the 3 months postpartum. And then really thinking back to what Mary presented on strategies from other states and what we've learned and heard, and what has been recommended and elevated to us from our contractors on this project, is really considering and being thoughtful about how we could utilize a pregnancy medical home or a health home model for that later postpartum period. So when you see 3 months postpartum here, don't take that as we are no longer looking at that full 12 months of postpartum. We absolutely are. It's just that we may use a different strategy for care for those remaining about 9 months or so. Okay, next slide. So how does VBP, so I've already said like a bit about this, but let me think, what can I add on? VBP is really based on the premise that payment is the driving force and something to leverage and utilize to change behavior change, provider behavior change, and then in some way at least delivery system transformation. It is believed, and again, there's evidence to show that VBP can achieve the triple aim of improved health, improved quality, and patient provider experience, and also more efficient spending. And it does this by reducing unnecessary and low value healthcare. That would be the lowering cost. By rewarding preventive and whole person care, that would be the better health or improved population health, and then rewarding the delivery of high quality care. Okay, I think that's good for that. Next slide, please. And so this is just, you'll see the reference credit down there on the bottom of the slide. This is from HCP Land. These are the various components of an episode of care. This is a pretty widely accepted kind of the standard definition of an episode of care. And really our reason for sharing it here is just to share with you all and with the audience. One, these episodes of care are complex and intricate, and many of these components, when you change one, it's going to change others. That's not always true. Like some of them are much more straightforward, like the episode definition and the episode timing, and even the patient population. Those are pretty clear. I think where we are currently in our design work is more on this right-hand side, and these are all kind of things we are actively investigating, and that is both in looking at research, it is in talking to other states and what they have done and how that has worked or not worked as intended. We're always interested in both kind of lessons learned on both sides of that, right? In terms of this worked great, and in terms of, yeah, we implemented in this way and it did not quite meet our goals, or did not meet our goals in these ways. So we are learning all of those things. We are also looking at our own data. Our analytics teams at the Healthcare Authority are quite busy and deeply ingrained in this project, so that we are maximizing applying our own Medicaid claims data in terms of any kind of decisions that we are making around the episode of care. So in looking at all of these components, these are really all the things we need to have scoped out with a plan and a design by the end of this calendar year, by the end of December of this year. Okay, next slide. So the last kind of bucket on that prior slide was the quality metrics. So we just wanted to share a bit more information, I would say, over the last few weeks at the Healthcare Authority. We've been having a lot more conversation around metrics. Again, what does the literature research say? What do other states say? And what can we learn and glean from them? And what do we see in our own data? So this is kind of, and I'll just share with everyone, like, the metrics are perhaps, well, there's still plenty of time before the end of the year, but at this point, one of the more challenging conversations, because one, we are limited in the number of metrics that we can include in the episode of care. They feel and are critically important, and we have to be practical around some of the feasibility considerations, which are really what are listed out here on this slide. I mean, we want to include metrics that have the science and the opportunity to really drive better population health. If that was our only criteria, we would probably end up with different metrics than what we will end up with, because we also have to look at what is feasible to require of providers and provider teams. And sometimes those two are not in agreement. And so you kind of have to get to the best that you can with the criteria for which you are evaluating your metrics. And so these are really the criteria that we are using to evaluate metrics. And we started with a list of, oh gosh, I don't even know, a lot, 50 maybe. Yeah, and so 50. We have worked down from that considerably, but we are still not to kind of our final decisions, but just wanted to share with you all that this is the process that we are following.
Yeah, and Beth, I would also add that what we have found when we've spoken with other states is that this measure selection process is not without controversy, right? Because there's always that discussion around, it may be aligned to your goal, but is it appropriate for this model to hold us accountable for this sort of a measure when we only can exert this amount of control or influence? And so we'll need to also have those conversations, and we'll just be continuing to work together around that. So it's just going to be something we'll be working through.
Yes, thank you, Mary, for adding on. That's really helpful.
And the other thing, and I forgot to mention, is also to call out that we are an MCO state, right? And so we're going to have to be mindful about how do we make sure we're engaging with and working with our MCO partners in this process as well. So it is provider, absolutely, but also our MCO partners to be just pulling this forward.
Yep. Okay, next slide. And I'm noticing the time, and I know we want to get to open time, and we will. I think we should have at least 10 minutes, I believe. So, so we've already kind of talked about these, right? There's the technical, practical considerations, alignment with, our goals. We want to make sure that our metrics are meaningful. And then these last two kind of align with what Mary was saying around the Healthcare Authority's environment and being a managed care state. This also certainly has to do with kind of what we are asking of our contracted providers and what is reasonable. We don't want to exclude people, and we just don't want to make people upset and make their lives really difficult. And we still care about the goals of this model and really increasing higher value care. And so threading that needle is not always easy or straightforward. Okay, next slide.
And Bob, I think I turn this over to you.
Yes, thank you very much, Mary. This really is just a high-level view of the schedule and the activities that you've already heard from both Beth and Mary that we've been doing. We've had a number of engagement sessions throughout the summer timeframe. We've worked with other states. We've made phone calls to them. We're continuing to do that. Here, we've kind of have gotten those environmental scans, and we've gotten some of that draft work done. And so here in the month of October and November, we are going back, like this session today, going back to our stakeholders and re-engaging with them. Also our tribal stakeholders as well. In fact, we've got a meeting tomorrow with them. And so what we're hoping to have from our partners at NORC is that here in the time frame of the October, November, that they are going to have a draft design document for us that we can be reviewing, and then having that final design here in the December timeframe. And so that's what you're seeing. And that doesn't mean it's all over and we're all done. No, you can see here in 2023, we are basically going to be taking a look at that. We're going to see is funding needed. We're going to be working with the legislature if that's appropriate. And then really we're looking at that January 2024 to really have this model implemented. So that's, again, sort of that high level of where we're at and where we're going.
Great. Thank you, Bob.
Thank you. Next.
All right. So as mentioned at the beginning, at the top of the hour, we're looking for your feedback. So we've teed up a few questions here, which is the initial feedback on key goals and identified levers for our maternal care model, or anything else shared today. And also, we'd like to hear any additional considerations we should address as we design this model, or if you have other questions for us. So I see that there are 7 questions / comments in the chat already. And Stella and Beth, are you teeing those up?
Yeah, I can read off the first one because I think it was a direct message to me. So the question is, some of the most impacted communities seek and trust supportive care outside of the OB PCP clinical care office. Will this model be inclusive of services not attached to clinical care agencies?
Outside of the OB PCP, so I also take that as outside of midwives as well, right? So we're talking about other associated, like, community-based, like CBOs or licensed behavioral health agencies, kind of. Is that the?
Yeah, and this question came from Maikia, and Maikia, you do have the ability to unmute. So if you wanted to add on to your question, that might be, and we might have just lost them. Actually, yeah, I think they might have logged out. So
okay, I can give it a quick shot just to capture it. I appreciate the question. The episode of care does have an accountable entity for the payment, also for the metrics or reporting. And so when we think about, if what this person is saying is like, hey, there's a whole system of care that we have and that we need to improve in terms of coordination and service delivery and navigation and all the pieces, I totally agree with that. In terms of an episode of care and just kind of the structure, if you think back to that landslide with all the pieces, one of them was the accountable entity. So that gets tricky when the question is, are we going to be including providers outside? There needs to be one accountable entity, which is really going to be the primary OB provider.
And, you know, I would just add on to that, Beth, one of the things that we heard when we spoke with New Jersey was that they were considering the inclusion of doulas. And because as is one of the stated levers that we're thinking about, you know, really wanting to make sure that there is access to doulas for our population, they specifically chose not to include doulas in their population in their bundle because they didn't want that additional expense to be something that would dampen the use of those doulas. So it really is, when you consider an episode of care portion, we want to be mindful around what are those cost centers that we include in that. But that's not to say that when we create our entire maternal care model, that there may be other considerations we have that would be, how do we incentivize and include those other non-healthcare system providers?
Great, thank you. And then I see a hand up from Louisa. Louisa, please feel free to unmute.
Hi there, Louisa Severn. I am calling in. I'm a member of the Midwives Association of Washington State. I'm a licensed midwife. I am delighted to hear that there is movement towards value-based reimbursement inside the system. I am really keen to just make sure that while you guys are pondering a move towards this for the system at large, that there is consideration given to those of us who work outside of larger healthcare systems. So the vast majority of licensed midwives work independently of larger systems. I know that there are increasingly LMs working with, for example, Quilted Health, which I know you guys are familiar with. But I know that I would really love to hear that you guys are contemplating incorporating, or at least chatting with community-based midwives as you are designing the bundle for maternity care providers, as well as hospital-based and systems-based providers as well.
Yeah, Louisa, thank you for your comment and for your work as a licensed midwife. We absolutely are intending to include community birth and continue to work through, you know, what that model looks like and what equitable reimbursement looks like. But we have explicit goals of increasing access to our Medicaid clients to midwifery care. And so
Great.
that is an important piece of this project.
Thanks so much. I appreciate that.
Great, thank you. The next question that I'm seeing is from Brianne. Is sexual and reproductive care outside of the scope of this model?
Oh, depends which, I mean, sexual and reproductive health can be, so I assume that you mean like outside. Here's, okay, I'm gonna go back to the land slide visually on both kind of the population and the episode definition. And so we're talking about folks kind of, oh, so look at that. From an initiation of prenatal care, again, for the episode piece, probably through 84 days postpartum. So any sexual and reproductive healthcare services that fall under that population and under that episode timing, this says 60 days, but we are really looking at 84 days or including the entire fourth trimester. Yes, I mean, absolutely. If we're talking about sexual and reproductive healthcare services in that later postpartum period, yes, I mean, I think sexual and reproductive health is critical to people across the continuum, but if we're looking at a pregnancy medical home model or a health home model for that later postpartum period, we will absolutely be holding in mind and including sexual and reproductive health, as well as behavioral health and chronic disease management and all the pieces. But if we're talking about sexual and reproductive health to folks who are not pregnant and not in that year postpartum, right, which is a lot of people, like that is not part of this episode of care or this maternal care model. I hope that makes sense. You can unmute if it didn't answer your question.
That was great. Thank you, Beth.
You're welcome.
Great. And the next question, did any of the states that were talked to discuss providers not wanting to participate and decide to stop taking Medicaid OB patients? This could be a concern in our rural areas if providers decide to stop taking Medicaid?
Right. Thank you for that question. And the state we talked to had a voluntary program, and the state we're scheduled to talk to has a mandatory program. So it will be interesting to hear if there is a difference between that decision not to continue delivery based upon whether the program is mandatory or voluntary. So I will look forward to continuing to explore that with the states, but the state so far that we discussed this with in detail, it was voluntary and so did not have that dynamic. And really appreciate though that we need to be thinking through the differences in the providers and the communities that we that our clients are seeking care in, right? And so we know that there are many groups that provide a large percentage of deliveries, and then we have, and I forget the statistic, I'll get it wrong, but it's like 75% or so of the delivering providers have 10 or fewer Medicaid delivered births per year. Beth, am I getting that about right?
Yeah, I think that's ballpark.
Yep. So and that makes it tricky, right? Of when you have so few births, but we also don't want to exclude those providers who are critical to our clients from the model that we developed. So we're going to have to take that into consideration, and really appreciate you raising that up. Beth has been a great champion in the team for not just having our attention focused on those larger those provider groups that have a larger percentage of our deliveries, but also to really be mindful around assuring that across the state we are providing services to those who have trusted their care to us.
Yeah, and that was great, Mary. And I would just add on, like, part of this project, we have a risk log, like from the beginning, that we were like, okay, if things go badly, like what would that look like? And I think our number one or something was exactly like, what if current Medicaid providers decide, I'm out, I'm no longer gonna provide care. Like, that was something we called out from the very beginning, is we have to be sure that we are, thinking of this as a very unintended possible consequence and how we avoid that at all costs. So I appreciate that other folks were thinking about that too.
Great. I think
one more, or is it time?
We are at time. So yeah, I think we maybe want to scroll to the last slide.
Yes. Great. Okay. So again, thank you for the great conversation and the discussions. Also saw that MSS is being brought up. Yes, that is another component that we are considering as we develop this model. And want to make sure as we're working towards this that we are building on both health homes and the maternity support services programs that we have. So here is where you can find more information on the website, as well as the contact information. In terms of the question about will these be posted? Yes, both the recording as well as this slide deck will be posted on our website, so please feel free to go there. And with that, of course, if you have specific questions or call outs for either Beth or myself, happy to respond to you, get this to the right place for a response. And really, again, appreciate everyone's time, and Stella and Bob for your fantastic support as always. And we look forward to having a final 2022 webinar like this towards the end of the year. So take care, everyone, and be well.